Welcome to the Stanford Women's Health Vodcast series. I'm Dr. Sharon Hung, Director of Women's Health for the Primary Care and Population Health Department at Stanford. From debunking myths to exploring the latest research, we will delve into the world of women's health with leading experts in the field. Today, I have the pleasure of speaking with Dr. Scarlett Gomez and Dr. Iona Cheng, who are both professors of epidemiology and biostatistics at the UCSF School of Medicine. They are both primary investigators of numerous trials, of which we'll highlight today their work on elucidating lung cancer etiology among Asian American female never smokers. Dr. Gomez is a co-leader of the Cancer Control Program at the Helen Diller Family Comprehensive Cancer Center and the director of the Greater Bay Area Cancer Registry. Her research interests include the role of social determinants of health, such as race, ethnicity, gender, social cultural factors, immigration status, etc., on health outcomes. Dr. Cheng is a co-investigator of the SEER Greater Bay Area Cancer Registry and has an active research program within the multi-ethnic cohort study that studies the racial ethnic differences in cancer risk. Dr. Cheng also specializes in conducting population-based cancer surveillance studies that highlight differences in cancer incidence and mortality rates across various racial and ethnic groups. Thank you so much for being here today, both of you.
Thanks for having us. It's great to be here.
Yeah, and before we jump in, I just want to recognize that Asians are a very heterogeneous group and that great diversity exists within the broad racial and ethnic categories that we'll be referring to today. And in fact, a lot of your work is focused on disaggregating that data so that we have a better understanding of the variability we see within the subgroups. Can you talk more about the importance of this type of research?
Absolutely. I can go ahead and start on that. As you noted, one of the affiliations that Iona and I both have is that we are investigators of the Greater Bay Area Cancer Registry. What this means is that we are actually designated by the state California Department of Public Health to collect cancer incidence information. So on every single person who's been diagnosed with invasive cancer in the 9 counties of the Greater Bay Area. We report that information to the statewide California Cancer Registry, as well as to the federal cancer surveillance systems, both the North American Association for Central Cancer Registries, as well as NCI's SEER program. And it's really through that mandate and that program that we lead that we have the opportunity and the responsibility to look very closely at the cancer surveillance patterns in different population groups. Given the large and growing population of Asian Americans and Native Hawaiians and Pacific Islanders in California, that's a population that we've been especially interested in. And being Asians ourselves, we also recognize the tremendous diversity, as you noted, in these populations. When we talk about the Asian American, Native Hawaiian, and Pacific Islander population, that comprises 40 different ethnic groups. When we look just at the Asian American population, that comprises 30 different ethnic groups, 100 different languages. So not only do we see the diversity in terms of the countries of origin, there's additional diversity layered on with regards to their immigration patterns and where they are able to or choose to settle. And a lot of this diversity plays into their risks and outcomes of cancer. So that's something that we've been working really hard over the years, is with the data that we collect to really disaggregate as much as we're able to. And I can say that when we have been able to do that, we really see significant heterogeneity in cancer patterns across the 30, 40 different AA and HPI groups.
And I think just to add to that, I think because traditionally Asian Americans and Native Hawaiian Pacific Islander populations have been aggregate, and we've been seeing those statistics, and it presents a very different picture in terms of what their health risk and their cancer risk are. And so we've been really active in trying to move that conversation. And I think there is more national attention. I think everyone is now recognizing that heterogeneity. And it's great to be able to see more focus on trying to build the data structures that needs to collect that information so we can present, statistics specific to each Asian ethnicity and Native Hawaiian Pacific Islander population group instead of it as an aggregate.
Great. And then, as I mentioned earlier, you've both done such extensive research on racial differences and health outcomes and cancer risk. And I really want to focus on the trends of lung and breast cancer in the Asian community today. So your research on the increased proportion of lung cancer diagnosed in Asians who have never smoked really caught my attention, and I'm so excited for this opportunity to highlight that work today. And in your research, you have seen that the incidence among every never smoking Asian American, Native Hawaiian, Pacific Islander group was higher than never smoking non-Hispanic white females and were highest in never smoking Chinese American females. Can you talk more about your findings so far and your ongoing research?
Yeah, so in fact, the interest in this research really started when our colleague, Dr. Heather Wakely, who's a thoracic oncologist at Stanford, approached us, I'd say about 10 or so years ago, with the question that she and her colleagues were seeing more and more Asian American women, no smoking history, present with lung cancer in their practices, in their clinics. What's going on? Are rates increasing? And logically, because we run the cancer registry, we're potentially, in theory, positioned to help to address that question. Unfortunately, because we don't collect smoking information in cancer registry data, at least not reliably, and that information is also not available in population-based census count data, population-level data. So those are the two pieces of data that we need to calculate rates in order to answer that question that Dr. Wakely posed. So together we launched the research program. We were funded by the NCI to conduct a study in which we linked electronic health records data with cancer registry data. And that was how we were able to finally obtain, derive the statistics that documented what were the rates of cancer among distinct populations of Asian American, Native Hawaiian, and Pacific Islander women by smoking status. And in doing so, we were able to elucidate what you noted, Sharon, is that we found that the rates of lung cancer among every ethnic group of Asian American, Native Hawaiian, Pacific Islander females who've never smoked were about 1.5 to 2 times higher relative to non-Hispanic white females, with the exception, though, of Japanese American women. Their profiles and their risk looked much more similar to non-Hispanic white women.
So I think this was a really seminal study because we needed to have those statistics to actually quantify the burden and to demonstrate the higher incidence of lung cancer across these Asian ethnicity groups. There have been additional studies that descriptive studies have confirmed this. Some similar work that's been done in Florida with their cancer registry data. Also some studies coming out of Kaiser Northern California, Kaiser Permanente Northern California, also observing similar patterns that we've documented within our EHR cohort that we established.
You mentioned Kaiser. My husband actually works at Kaiser. So I actually first heard about your work when he came home from a meeting and he insisted that I sign up for your FAN study. So I'm just curious. I think, this research obviously will build a lot of, anxiety and concern among Asian American females. Is there any data on what symptoms these women generally present with yet, or what risk factors they might be more likely to carry, so that we aren't missing these cases in primary care?
I would say that there are several well-established risk factors, but I will also note that specific to Asian women, these are all based on studies done in Asia. There's actually, and the reason for that is because there's been no study among Asian American females who've never smoked. Our FAN study being the first study to look at to try to identify the etiologic risk factors. But the studies that came out of Asia have shown that the following risk factors for lung cancer among females who've never smoked, including exposure to secondhand smoke, prior lung diseases, specifically tuberculosis and COPD, exposure to air pollution, certainly, but I think here we're talking about fairly high levels of air pollution that are known to exist in parts of urban Asia. Family history of lung cancer, and exposure to indoor air pollution, specifically using coal or wood to heat the house, as well as cooking oil fumes, especially in the presence of inadequate ventilation. So those are the known risk factors, and those are certainly things that we can tell women to be on the lookout for and to try to mitigate and personally, as well as to, I think, inform clinicians and providers who should probably be on the lookout for one or more of those risk factors among females who've never smoked. In terms of signs and symptoms, I think they're really just kind of the standard set that the, organizations like the American Cancer Society recommend to look out for. Things like persistent cough, anything that's unusual in terms of weight loss, pain in different parts of the body. And I think just, I feel like we've had with regards to, as a part of recruiting for our FANS study, we've really had the tremendous opportunity and honor to be able to raise awareness around this topic. Your husband, who works at Kaiser, probably heard about the study from our colleague at Kaiser Permanente, Northern California, Dr. Jeff Velota, who's a surgeon there, and he's just done an incredible job with, raising awareness around this issue. And I think what that does is that it helps both patients and clinicians just be more aware that this is something that does seem to affect our population of women, perhaps more so than other populations. And so just to be more aware of some of these symptoms and signs if they should arise.
And I think, part of our FAN study is that we have a great group of a community advisory board, including patient advocates, who have been just very courageous in sharing their stories with us and experiences that have helped us, inform our study and raise awareness. And they share stories with us in regards to them presenting, with a cough that doesn't seem to be anything abnormal, right? A pain, right, in their back or whatever it may be. And the challenges for lung cancer is that often it's detected at a later stage, right? And for the later stage cancer, it has a poor prognosis. So that's really where we need to move the field, is trying to really understand who those may be at risk, being better to understand, and as Scarlett mentioned, raising awareness among providers, among the Asian American community, that this is a disease of higher burden among Asian American females who never smoke. So they can be attuned to like, oh, actually, maybe I should check this out. Maybe I should ask. Maybe I should, raise this question, to my physician. So I think that just increasing this awareness, and also for the field to try to address this question, we do not have a way to screen for lung cancer among non-smokers. And that is a huge gap that we need to fill. And if we can address that, I think that will really help, move the field forward in being able to address this higher burden.
I see. So yes, thank you for sharing the risk factors that we know of from those studies in Asia. And I know, like you mentioned, this is a new ongoing study, but I'm just curious if you have any suspicions or thoughts about risk factors that might be unique for Asian American women versus those that are from Asia.
The risk factors that I noted that were identified based on the studies in Asia, we do hypothesize that they may potentially not be as relevant among Asian Americans, just because the prevalence is much lower. And so we're talking about very, very high levels of air pollution. Certainly we see that here in the US, but generally not quite at the same levels as some parts of Asia. Cooking oil fumes, we don't know. It's never been looked at how prevalent that is here compared relative to Asia. And certainly cooking with, natural fuel sources inside the home, or heating the home using things like coal and wood burning is certainly not as common here in the US. So we do suspect that there are other factors that may be at play. We have some hypotheses based on some of the studies that also have been coming out of Asia, and those are what we're looking for. There's also the potential that the question you asked about whether the risk of these factors may be different for Asian or Asian American women, maybe relative to other ethnic groups. And so I think that does raised a question, right, of whether there's a genetic or component to this, if there's greater inherited susceptibility. And maybe with that, I'll turn that over to Iona, given her background as a molecular epidemiologist.
So I definitely think that there's a combination of genetic susceptibility, also in regards to acquired somatic mutations. We do know that Asian females do have a higher proportion of a specific eGFR mutation. So there likely is some combination of genetics as well as environmental at play that we think could be posing a higher risk for specific Asian ethnicity groups. I think another aspect of our FAN study is that we are trying to address when these exposures may be happening that may be most relevant for cancer development, right? So asking, what were your childhood exposures, your early adult life, your midlife exposure to some of these questions, because trying to understand that period of susceptibility, right, that could influence, because lung cancer is a disease that does take quite a bit of time to develop, right? So us trying to be able to hone in on when that period of exposure may be most relevant for developing disease, which we hope to try to answer through our surveys that we're administering.
I see. Yeah, you mentioned a number of things I want to expand upon. So in terms of, I did read a number of studies looking at that the eGFR mutation was more common in lung cancers among East Asian never smokers. What exactly is the significance of that, and how does that impact prognosis?
So having the eGFR mutation, there are specific targeted therapies that address that. So with that, and that have done well in extending the prognosis and health outcomes for women diagnosed with lung cancer. And so there is a higher frequency of this mutation observed among Asian populations. And with that comes with this very targeted treatment therapy that can help extend outcomes for these women.
I see. And do we know if Asian American females who've never smoked or are diagnosed with lung cancer generally present at a younger age, as in the average age of lung cancer diagnosed in the US is currently around 71. I'm just curious if that age is similar or younger.
So there has been some work that's been done to look at that question and have seen actually in comparison among Asian American females and to Asian males, actually a slightly younger age of diagnosis among Asian American females. So I think it was around maybe around the average around 65-ish. And then it was a couple of years older for Asian males. So we are seeing that presentation in the data. So, I think often when we think about cancers in general, when they do occur at an earlier age, that usually does point to something related to genetic susceptibility. So I think there's some element of that could be at play here.
I see. And earlier, Iona, you mentioned screening a little bit, and as you all know, it is currently recommended that adults aged 50 to 80 who have had a 20-pack year smoking history and currently smoking or have quit within the last 15 years be screened for lung cancer with an annual CT, of which, of course, none of these non-Asian smoking Asian women would qualify for. And in terms of absolute numbers, I believe that there are about, over 20 lung cancer cases per every 100,000 Chinese American females who have never smoked. Can you put that into perspective by comparing that to the approximate rate of lung cancer in those who currently qualify for lung cancer screening based on their smoking history?
So I think the rate that you're referring to came from our paper where we estimated the rate of lung cancer for the different AA and HPI ethnic groups for females who've never smoked. And I think the 20 per 100,000 is the age adjusted rate that we observe for Chinese American females. And we sort of footnoted that made the lung cancer among never smokers the third most common cancer among Chinese Americans. I think that it's still much lower than the rate of lung cancer among smokers. But I think that we would never have a screening guideline that is just that would apply to all never smokers. I think we would likely, if there ever were a lung cancer screening guideline that were developed for never smokers, it would be a program that's similar to what they're doing in Taiwan, which is selecting high-risk individuals who are never smokers on the basis of one or more established risk factors. And so these are risk factors that include having a family history of lung cancer, exposure to secondhand smoke, prior lung conditions, specifically TB and COPD, as well as exposure to cooking oil fumes. So having one or more of those risk factors would basically qualify you to be, you're considered high risk and would qualify you for screening in Taiwan. According to the TALENT study, which is a screening trial that was conducted among never smokers in Taiwan, they found that that when they screened individuals who were considered high risk on the basis of those risk factors, the rate of detection with low-dose CT was actually on par with, if not slightly higher than, the rate of detection for the large screening trials that were done in the US and in Europe. So I think that indicates to you that, you know, when we focus in on those high-risk individuals of never smokers, according to the one trial in Taiwan, that it could potentially be, you know, it could be picking up lung cancer at the same rate as far as heavy smokers within those age ranges here in the US.
Yeah, thank you for sharing those screening guidelines that are in Taiwan. I didn't know that, and I always think it's so interesting to hear about how screening guidelines are so different in someone's kind of ancestral country of origin, which may be more relevant to what we have on a population level in the US. So I am curious, you know, and I know this might be somewhat of a premature discussion, but for both of you, is there any changes that you would personally like to see in our screening guidelines, such as an adaptation of what they have in Taiwan? That would catch more non-smokers at an earlier lung cancer stage?
So I think definitely, we're advocates of, our study and other works being able to provide the data that's needed to inform changing screen guidelines to address those who never smoke. I mean, that is a major priority. So definitely there are people in the field working on that, but we need more data such as our studies and other studies that can provide robust evidence, right, in terms of what are the risk factors, right? So we can similarly, as a talent study has identified, these are at least established risk factors. We know these people are more likely, are at higher risk of developing lung cancer. So to inform those guidelines. So we really need to build and fund that evidence base to be able to move and have those type of screening trials work done here in the US.
Great. Yeah, I'm so excited to see what your research brings in the future. And before we move on to our next topic, is there anything else you guys wanted to add about this topic?
I think maybe the only thing that we'll add is that specifically with regards to the FAN study, this is a study that is, as we mentioned, the first and currently the only study we know of that is looking at trying to identify lung cancer risk factors, specifically among Asian American females who've never smoked. And I think says something that NIH, specifically the National Institute for Minority Health and Health Disparities, elected to fund the study. I think we need more. And I think what has come about with this study is, again, just the opportunity to really raise awareness nationwide and globally around this issue so that we are more aware of what our burden of this disease is. We are coming up on the last year of recruitment for our study, and it is a case control study, and so we are recruiting women diagnosed with lung cancer as well as those who weren't, so that we can make comparisons of these risk factors between the two groups. And we are still looking for participants, and so whoever is listening to this podcast, we would encourage folks to refer participants to the study. Thank you, Dr. Hung, for volunteering for the study. We're especially in need of much older women. As you noted, the average age does tend to be older. And so in the Bay Area, we're especially looking for women, Asian American females who've never smoked over age 80. And in Southern California, we're really looking for women over age 60. Those are kind of the groups we're still looking to fill. But I think also just getting the word out about just raising awareness around the topic is just as important.
Absolutely. Thank you both for this work.
I think I just wanted to end just to acknowledge that there's been such a tremendous response from the public and from patients telling their story. And I think it's garnered a lot of attention, both nationally and internationally, and just really appreciating, because I think many people are affected by cancer. And I think because there hasn't been as many conversations in the Asian American community about their experience with cancer, and the fact that there are women sharing their stories about their experiences, we think about lung cancer as a disease among those who smoke, right? And we're recognizing that's not the case. And so just really appreciate the fact that there's just been increased spreading of the word of this being a disease among the Asian American community.
Yeah. All right. And then so just moving on to breast cancer in Asian American women. So historically, breast cancer incidence has been lower in Asian groups compared to non-Hispanic whites. However, breast cancer incidence has been increasing in Asians over the last 30 years, while it stayed relatively flat for non-Hispanic whites. Can you expand upon some of these trends that we've been seeing?
Yeah, definitely. So as previously mentioned, because of our role and responsibility within the cancer registry community, breast cancer is another one of those cancer sites that we've been really keeping a close eye on with regards to its patterns and trends, specifically among Asian American, Native Hawaiian, Pacific Islander women. And in doing so, we and others have noted that here in the US, we are seeing steadily increasing trends of breast cancer. Some older studies that we've conducted that have had the data to be able to disaggregate the groups have shown that we are seeing this trend in basically every group of Asian American, Native Hawaiian, Pacific Islander women that is increasing trends over time. Again, though, with the interesting exception of Japanese American women, whose patterns look much more similar to non-Hispanic white women. This is sort of running in parallel with data that have been coming out of Asia. Showing that across many of the countries in Asia, we're also seeing very rapidly increasing trends of breast cancer. And in fact, in some of these papers, the authors noted that if these current rates of breast cancer, these current trends keep up, Asia is on pace to have the highest rate of breast cancer worldwide. We unfortunately have not had the data to be able to continue the monitoring of looking at breast cancer incidence trends in distinct AA and HPI ethnic groups. But when we look at the group combined as one group, even though we said earlier we should not aggregate, unfortunately, we don't have the data to disaggregate. When we do look at AA and HPIs as a group, we've seen that just over the past 5 years, specifically the period from 2016 to 2021, that trend of breast cancer has really kicked up. We're now seeing an average annual increase of 3.3% per year of breast cancer in AAPIs, AA and HPIs as a group in the US. And in younger women, that is women under age 50, that rate of increase is even higher. It's 3.85% per year. And what we're seeing is that in the last data point that we have, 2021, the rate of breast cancer among Asian American, Native Hawaiian, Pacific Islander women under age 50 is now the highest of all other racial ethnic groups in the US. So it's crossed over the rate for non-Hispanic white women.
So I know a lot of your work is in kind of, gathering all this data, and you might not have the answer for some of these questions I'm about to ask, but I'm just curious, do you have any thoughts on why Asians, AA and HPI groups tend to present at a younger age, and we're seeing an increased incidence in Asian American women who are less than 50?
So I think you asked a really good question. So, given our role in the cancer registry, we are responsible for generating the descriptive statistics, looking at the rates and trends in different population groups and over time. And oftentimes when we see emerging patterns, like what we see for lung cancer and for breast cancer in Asian women, that prompts us to to pose the hypotheses and ask the research questions, and then we try to apply for additional funding to address those. And so in the case of breast cancer, we have a study that's been going on for 1.5 years now. It's called a CRANE study. So it's also a case control study that's trying to exactly answer the question that you asked. What do we think is going on? Why are we seeing higher rates among younger Asian women? What are the risk factors beyond those that are already well established and known to cause breast cancer? The answer is we don't know. We don't know why we may be seeing this higher rates of breast cancer among Asian American women. As Iona mentioned earlier, with lung cancer, oftentimes when you do see an earlier onset, higher proportion or a higher rate of earlier onset cancers, it potentially may indicate genetic susceptibility. It may also potentially indicate, early life factors that women were exposed to and maybe at a higher rate for particular racial and ethnic groups. So those are some of the areas that we're kind of trying to hone in on in our CRANE study.
So I'm excited to see the results of those as well. There's so much that we still need to learn, it seems. And as you know, the USPSTF recently changed their screening guidelines to start at 40 instead of 50, which will hopefully help address some of the racial disparities that we see when it comes to breast cancer. But according to the CDC, Asian American, non-Hispanic Pacific Islanders are less likely to undergo age-appropriate recommended screenings for breast, colon cancer, cervical cancer. I'm curious what your thoughts are on the kind of unique challenges and current barriers to improve screening rates in this population specifically.
So I think, I think in addressing this question, I think for, the Asian American, Native Hawaiian, Pacific Islander population groups, I think there are elements to consider in regards to these specific ethnicities and cultural influences, also understanding issues surrounding language, right? Surrounding their neighborhood environment, their access to care. So I think all of these type of elements factor into, their participation in screening. Also, I think in the Asian American culture, cancer, is sometimes can be perceived as this, a topic you don't talk about, right? And so there's, I think, these various elements, cultural elements, also resources elements that are distinct for specific Asian ethnicity and Native Hawaiian Pacific population groups that need to be addressed specifically to help, increase the ability for these populations to get screened.
We did a study a number of years ago that was specifically focused on understanding what are the multi-level predictors of colorectal cancer screening for South Asian Americans. And we collected data from community members, both in a qualitative and focus group setting, as well as we analyzed quantitative data. And one particular factor that emerged from both of those types, all three types of the interviews that we did and the data collection that we did, was this concept around preventive, sort of a preventive health orientation or mindset, which tends to not be present in many Asian cultures. Some of the themes we heard from the focus groups were, if I don't feel sick, if I feel fine, why do I need to go see a doctor? And coupled with that, in the quantitative data analysis we did, we found that actually the biggest predictor of colorectal cancer screening among South Asian Americans was also having had a flu shot in the past year. It's makes no sense. But then when we looked into it, and in fact, Kaiser, Northern California, was the first to implement a program called Flu Fit or Fit Flu. I can't remember what they called it, where the people went in for a flu shot. They were also given a fit test. And so, we, in that analysis, also like to see, was this association only seen among Kaiser patients, but we noted that it wasn't. So to us, it indicated that individuals, South Asian Americans, who had had a flu shot in the past year were also those who adhere more to a preventative health sort of mindset or framework or orientation. And they were also then therefore the ones who were more likely to get cancer screening. So oftentimes these preventive health behaviors sort of go hand in hand. And I think, to Iona's point, that is a unique cultural aspect that may be underlying why we see lower rates of cancer screening among many of the Asian American ethnic groups.
Yeah, I can definitely resonate with that quote you just gave. I spend a lot of time convincing people to get screening who think that, oh, I don't have any symptoms, I'm fine. So definitely a common perception, I think. And we also know that Westernization has a major impact on breast cancer rates, since it can affect, parity rates when someone has children, if they're breastfeeding, et cetera. But when you, Dr. Gomez, did a study looking at US versus foreign-born Asians, you saw an increased risk of breast cancer in foreign-born compared to US-born AAPI. And could you elaborate more on that?
Yeah, so this was a study that we published, I want to say about 5, 6 years ago now. And it was a totally unexpected finding. We did not expect to see that higher odds, which are a proxy for risk of breast cancer among foreign-born Asian American women relative to US-born Asian American women, because that is counter against the traditional paradigm that we know of breast cancer risk, which is associated with acculturation and Westernization, as you noted. So this was the first study to show that pattern. And in fact, last year, a totally independent study, but also set in the Bay Area, found the same thing. And in fact, that study had a larger sample size. It actually came out of Stanford. And that study had a larger sample size. And so they were able to further disaggregate between birth cohorts. And they found that association, higher risk or odds of breast cancer among foreign-born relative to US-born, was actually a stronger association among recent birth cohorts. And I think it actually fits in line potentially with these rapidly increasing rates of breast cancer we're seeing in Asia. And given the fact that both of these studies independently found the same thing, they were both set in the Bay Area. When we think about who these recent cohorts of foreign-born women are, who have this increased risk of breast cancer, we think about who immigrated here to the Bay Area, a very high cost of living region, over the past 10, or 20, 30 years. And it's potentially the women who are already at very high risk coming from Asia, where rates of breast cancer are rapidly increasing. What's interesting about both of these studies also is that they adjusted for a whole host of all the known breast cancer risk factors and found that pattern still persisted. So that means that there's something else going on, some other risk factors going on that's we don't know, that's underlying that interesting flip in breast cancer risk.
And earlier you, Dr. Gomez, you mentioned the kind of the FitFlu program that they're doing at Kaiser. And I'm just curious, are there any other prevention programs or strategies that you've seen that have personally worked well in the Asian American community that we can maybe extrapolate from and apply to some of the cancers that we talked about today?
I don't know that there are. I think that some of the interventions that really rather than waiting for expecting the community or community members to come to us as medical providers versus us bringing the services out to them. I think it's those ones that bring the services out to them, but that are also done in a culturally responsive and appropriate and tailored way, generally have been the ones that are most, I think, successful. This is not looking at screening, but we did a study several years ago where we were really interested in trying to understand what could be explaining the higher rates of mastectomy among some Asian American women diagnosed with early stage breast cancer. This was something, again, an observation we were seeing in cancer registry data. And we were interested we conducted a study to try to understand further. some of the hypotheses around that were that women have smaller breasts to begin with. And so oftentimes, even for early stage breast cancer, breast conserving surgery may not be indicated. But what we found was that there was this interesting pocket of women, specifically women living in San Francisco, Chinatown, who were having breast conserving surgery at about the same rates as other ethnic groups of women. So they were not having mastectomy at a higher rate. So we conducted qualitative interviews with them, and we try to understand why. What enabled you to choose, or why did you choose having a breast conserving surgery versus mastectomy? And what we were hearing from the women in a Chinatown in San Francisco was that there were wraparound services that were provided that enable them to be able to go to a clinic, every day for 6 weeks to have their radiation. There were people who, somebody helped them make the appointments. Somebody actually showed up at their door every day to drive them there and drive them back. If they needed elder care, if they needed child care, there were people there to provide that while they were there, had to go to the clinic to get their radiation. Everything was in language, so they could actually understand what was going on. And so I think that's just an example. Again, it's not screening, but I think it's an example that when you tailor the interventions and you bring it to the community and you understand what are these wraparound other types of social determinants and social needs, that would help them to be able to engage in that intervention, whether it be screening, whether it be treatments. I think that's what's needed to really reach the communities and to bridge that divide, because I think getting medical care is not just about going, not everyone has the means to be able to travel to a clinic, find parking. We've UCSF, and I think it might have been specifically Zuckerberg San Francisco General. I recall being in a meeting and they had done a survey of all their patients, and they asked them, what are the barriers for coming to UCSF? And transportation and parking were like the top of the list. It wasn't health insurance. It wasn't, taking time off work, and those were all part of the list, but the top of the list was getting there. So I think if we could bring it to them, that helps eliminate that one barrier.
So thank you for that summary of some of the findings that you found. I think it's definitely gives me something to think about in terms of knowing that transportation is a big issue for some of these patients. And you mentioned providing people with information in a language that they are more comfortable in. Is there anything else that you think that I should think about as kind of an individual provider in my practice to help improve screening rates for breast cancer and other cancers?
So I do think one thing, just in principle, I think in regards to cancer screening in the US, I think if there could be more consolidation in terms of, you go for your breast, you go for your colorectal, or it's disjointed, right? So if there's a way for individuals to go in, I'm going to get all of my cancer screening done, right, in a coordinated, one-time efficient process. I think that would help, right, versus this, because it's so variable, right, and when it happens. So if there could, for me, I feel like if there's more, consolidation in cancer screening, I think that would help improve the screening rates.
I agree with that, actually, and I wonder if that's a lesson we can take from some of the Asian countries, because I know that people go once a year, once every other year, and they spend half a day, at their doctor's office, and they get everything done. I think also really paying attention to those social needs and understanding what are the social determinants of health that either promote or prevent, individuals from being able to take advantage of the screenings, I think is important as well.
Yes, thank you for bringing that up. I have noticed a lot of my patients who go to Taiwan or China, they're very excited to bring me back their 10-day report that they did in one day of their CTs and mammograms and colonoscopies. So I can definitely see how that would be taken up with excitement for some of my Asian American patients. And just kind of wrapping up, are there any, we talked a lot about just increasing awareness that Asian Americans who don't smoke are still at a very high rate of developing lung cancer. Are there any other key takeaways that you'd like to leave for the primary care providers or patients that might be watching?
I'll add, and then I'm sure Iona has thoughts as well. I think, again, just because I, am Asian myself, and so this, I think observation is coming from both a personal as well as a professional point of view, is that I really think that the stigma around cancer in our communities still is very much real, and it still very much exists. And I think that to the extent that we can talk with communities and patients about the familial risk associated with cancers, many of my generation peers that I know, they don't know their own family history. And sometimes it comes well after the fact. I recently learned just in the past few years that my grandmother been diagnosed with some kind of GI cancer, 40 years ago. And when, cancer affects any of my family members, it's still very much hush hush. And so as a result, we don't know our own family histories. So I do think that that's important to sort of convey to our communities and our patients that it's, it may be, it can still be very private, but your risk, your risk can affect your family's risk as well. And I think that it also helps us to be more vigilant. And so, as Iona mentioned earlier, when we do experience something that feels off with our own bodies, we have more knowledge and more power to know that, oh, actually, these cancers are rising, and we are at high risk for these cancers. So maybe I need to talk to my clinician about this.
Yeah, thank you for bringing up that example, Scarlett. I try to train my residents. Oftentimes we take a family history at the first appointment and not necessarily ongoing, but so important to ask at every visit, have you learned anything new about your family history since the last time we spoke? Any other lasting words you wanted to leave us with, Dr. Cheng?
So I think just in terms of, as we heard from patients, and I think the dialogue is changing, I don't think we are dispelling the myth that Asian Americans, Native and Pacific Islanders are at low risk of cancer. They don't get cancer. Questioning, the statistics are out there that paint this really rosy picture. And so just to be aware, right, that yes, cancer actually for Asian Americans is the leading cause of death for this racial ethnic group. And just being attuned to, right, the misnomers that can happen when you're looking at the aggregate statistics. We are changing the field to be able to show disaggregated rates across specific ethnic groups. But in absence of that, to be able to really recognize, right, that this is a disease, that affects many in our community. So being attuned to that.
Great, thank you. Dr. Gomez, Dr. Cheng, thank you both so much for being here today and for the work that you both do, which is so important for expanding our public health measures and improving our screening guidelines. I really appreciate your time today, and I can't wait to read more of your research on the topics that we're still exploring that we mentioned today.
Thanks so much for having us.
Thank you. We really appreciate it.